Hello, I'm Dr. Molescu, and we are now week 4 in your microbiology journey. So one more week to go. So we're going to do chapter 7, and my next recording will be chapter 8. So this week is crucial that you get everything done and completed. If there's any late work, must be completed by now, or it will be too late. Next week is the last week of our course. All right, so without further ado, let's begin chapter 7. It's all about how to get immunized. Why do we get immunized? Why should we get immunized? And with infections, how do we deal with them? Antimicrobials. All right, so people always assume antibiotic, that's for antibiotic, is for bacteria. And, you know, the layperson will always say, oh, well, why didn't you give me an antibiotic? Well, because you have a viral infection. So there's there's limited choices when it comes to viruses. Yes, there are some antiviral therapies, but I will tell you, you got to catch it early on. As soon as you get infected, onset of symptoms, it will lessen the severity. But we don't have the advancements that we do with weapons against bacteria, which is basically antibiotics. So we're going to go over that distinction, as well as antiparasitics and antifungal therapies. So let's begin. So without, I explain this every single week, so you should know. Without reading ahead, this lesson that I'm giving you won't have as much impact. Okay, so I don't care how you do it, whether you read the chapter and then you listen. I think that's the best way. But if you're one of those last minute Nellies, and you're listening right now to my recording and then reading, that's okay too. But as long as I know that you're reading the chapter, because there's a lot more detail than what I'm exposing you to here during this, I would call it a micro lesson. Other people would probably say it's too long. So I'm all for 5-minute lessons, and that'll be just like on one particular topic. But this is a broad topic, so it's going to take me a few minutes, probably about 20 to 30 minutes to discuss this. And like I said, without reading the book, it is not enough. Okay. So we're going to first learn about terminology and concepts that you need to know for this chapter, understanding what immunization entails. And again, it's an outline form, so I'm not giving you all the information. You need to, if you're really truly interested, go above and beyond and do your research. Go to the National Library of Medicine. Look up the latest in immunization therapy. The latest and greatest antiviral immunization, like we have now for COVID-19. How does it work exactly? All right. Understand the biochemistry behind it. All right. Antimicrobials, like I said, it's a plethora of therapies that don't just, it's not just one branch antibiotics. Okay. And then we're going to talk about active versus passive immunity. So passive immunity, an example of that is a baby is the mother is nursing, the baby is breastfeeding, and the baby is getting antibodies passively from the mom. That also happens in utero via the placenta. So that's passive immunity. Active immunity, an example of that would be you're injected with components of the virus, attenuated. You're actually sick and you get the infection. All right. That's active immunity. When you just get the antibodies against an infection, that's not active immunity. So we're going to go over the differences between that. All right. And understanding, and this is huge. This is the chapter where we go over overuse of antibiotics. Okay, antibiotics are way overused, probably due to, unfortunately, patient pressure. Okay, I've been there, done that as a practicing physician. Well, why don't you give me anything? Well, Let's see if your body can fight it. And if it's viral, you don't need an antibiotic. Now, can you get a superseding infection after you've been exposed to a virus and you've been fighting it for, a good 5 days and you're failing at it? Your immune system is overwhelmed and now opportunistic organisms take over, including the bacteria. And that's what typically happens with, I know because I have asthma, people with asthma are more prone to getting bronchitis, because what happens is we'll get a viral infection that Joe and Jane get, but when you have asthma, now you're more susceptible and your immune system is fighting the virus very, very vigorously. And unfortunately, that severe inflammation is going to also cause some more issues, which then put your immune system into overdrive, and any bacteria that's around will take over. And now all of a sudden you get a bacterial infection. You can end up with bronchitis and pneumonia. So that's, why we try to really use the antibiotics effectively and not overuse it, because if that person gets infected over and over again and you've overused the antibiotic, mutations have arisen out of the overuse of antibiotics. And then, of course, what happens is resistance. The resistant strains have taken over in that individual, and so the antibiotic is now pretty much useless. So years ago, we had penicillin, we went to cephalosporins, then overuse of that. We ended up with MRSA, which is methicillin-resistant Staph aureus. And the cephalosporins were perfect for Staphylococcus aureus infections. Staph aureus is on your skin, but when it's in large numbers, it can cause an infection. All right, after that, we went to vancomycin. Overuse of vancomycin. Then before you know it, I think it was by the late 1990s, I was already in residency. They came out with a new one, Cubicin, and it was $3,000 for an IV infusion per day, because it was new. So again, that one was to combat resistance to Staph aureus, even with vancomycin, and we call that VRSA, which is vancomycin resistant Staph aureus. All right, so you get the picture. That will be the last portion of our discussion. All right, so disease is someone that's not at ease. So, it sounds really corny and banal, but yeah, disease literally means that someone who is not at ease has a disease. So we need to find the root of the disease. The etiology means root. So the terminology that you will frequently see in the medical world, what's the etiology? Meaning, what's the cause? All right. The body fails to function properly when it is in the presence of a pathogen. You know it, you've been there, you just don't feel right. When you're coming on to something, you're coming on with something, and you get you got fatigue, your chills, your fever, your sore throat, scratchy throat, maybe stuffy nose. All right, these are all signs and symptoms. And you know what? How do you tell COVID from allergies from a simple, rhinovirus? It's hard, okay? But some symptoms are more severe than others. And so how do we find out, like COVID versus other different viruses? Well, we know that, typically it was a loss of sense of smell. That was huge. And that was pretty much, yeah, you definitely probably have COVID, but let's do the PCR test. Okay. So the signs, the objective signs that you see that can be measurable, and the definitive is usually a test, right? So how do we measure it? Doing the test, and the definitive diagnosis is doing the test and getting a result. All right. So the symptom may be subjective based on the description of the patient. What does that mean? It's the perception or that person's reality. Unfortunately, symptoms are not objective. They cannot be measured consistently across the board from patient to patient. My symptoms of COVID may be slightly different than your symptoms of COVID. I'm using COVID as an example because obviously this has been front and center for the last 2.5 years, right? Now, syndrome. Syndrome is basically a special grouping of signs and symptoms. All right. So, for example, I'm going to give you an esoteric one only because I know I have it. Ehlers-Danlos syndrome. What is it? Well, it's a series of signs and symptoms and diagnostic findings that are correlated to that particular syndrome, right? Super hypermobility. The collagen disorder can cause a variety of things, stretchy skin, typical heart valve issues, all kinds of other issues, not just related to the joints and muscle and skin and all that, right? Because collagen is everywhere. All right, so that's what a syndrome is. Okay, so now you understand the difference between just one symptom or two symptoms, maybe even three. Where you have syndromes, it's like groupings of many signs and symptoms. Okay. Diagnostic or identification of disease. Do you do a blood test? And do you get the results in the blood test? Do you do a nasal swab? Do you do a throat culture? What do you do to identify the disease? So in this case, we're doing microbiology. How do we identify the pathogen? We went over that last lesson in much detail, as you remember. Now, prognosis is outcome of the disease, right? So what is the prognosis? Okay. How well do these patients do after they've been infected, right? What is long-term COVID? That's an example, right? And some people have it, some people don't. Okay. Chief complaint. When you write a SOAP note, subjective, objective, assessment, and plan. For those of you becoming medical practitioners, whether you're going to be a doctor or a nurse, everyone has to follow that format. Okay. So the chief complaint is going to be part of that subjective of the SOAP note, progress note. All right. Etiology, as I said earlier, is cause of death. Now, someone who has a chronic condition is an individual that has been diagnosed with a disease, and the disease is not going away. We don't have something to resolve the disease. I don't like to ever use the word cure. We never cure anything. Okay. We manage symptoms, or symptoms go, like for cancer, go into remission. All right. You may go into remission, but we don't cure anything. Okay. So a chronic condition is something that the patient manages for the rest of their life. Okay. Nothing bothers me more than when I used to, and I'm sure you're going to come across this. I mean, I deal with it, obviously, I dealt with it, but it is a little bit annoying when someone says, well, I don't have diabetes. I don't have diabetes. My sugar's normal. I'm like, yes, and what are you doing to manage it? All right. Just because your blood tests are normal and everything seems normal, it is not. Okay. You are managing it. Are you managing it with diet? Are you taking glucophage, glyburide? What are you taking? What medication are you taking? Are you doing it? Obviously, if they're doing insulin, they say, yeah, I have diabetes. But the ones that are really on that cusp where they're diet controlled or they're just taking a pill, they'll just say, no, I'm fine. I don't have diabetes. Yes, you do. Or same thing. I don't have high blood pressure. Well, yeah, you don't, because you're taking a pill. Or are you, again, diet controlled and exercise for your hypertension? You always want to dive deeper when you are questioning patients, because they'll say they don't have something, but in fact, you look at their progress note and it says right then and there, hypertension, NIDDM, non-insulin dependent diabetes mellitus, okay? So make sure you're aware of that. That's super important when you are out there practicing, whether you're a nurse or a physician. Okay, now acute condition is something that is a quick onset. It's short term. It shouldn't be long lasting. So an acute condition isn't it, like example is an acute infection, strep throat. It's not going to be something chronic, right? But like, let's say you got, so gosh, let's say you went to the woods and you were camping out and you were in the Northeast, I don't know, let's pick a place, Pennsylvania, Pocono Mountains. All right, you're there and you come back with these symptoms, fever, chills, joint pain, and they do a test and they figure out it was a tick bite and it looks like a bullseye lesion. What am I thinking about? You know what I'm thinking about. Bullseye lesion on the skin, Lyme disease with joint pain, fever, chills, yada, yada, yada. They take the antibiotics. By the way, it's a couple months. It's serious. And now Lyme disease turns into an arthritic condition, chronic arthritis secondary to initial infection from the tick, which carried the disease, the bacteria Borrelia burgdorferi. That's an example of going from an acute condition to a chronic condition, okay? Another example is the Epstein-Barr virus. This is the kissing disease, right? The kissing disease, because we're sharing cups or you're kissing someone and you're, that's the vector. We talked about that last week. And all of a sudden now you're getting signs and symptoms of fatigue and low-grade fever and chills, yada, yada. You do the blood test. Lo and behold, you have EBV, Epstein-Barr virus. Now, the acute infection, you have acute signs and symptoms, yada, yada. But then what happens is after the acute condition has ended, you go into this remission. The virus never really goes away. It's kind of latent in your body. And then when there's a stressful event, you're not getting enough sleep, you're not eating well, you're stressed out, I don't know, you're managing 2 jobs and kids and going to school, bam, it hits you hard. You get Epstein-Barr virus back into the acute phase, and now your symptoms are based on an acute condition. All right, so that's called a relapse back into the acute phase. Okay, so these are terms that you need to remember because we're going to come across all of these across all the different conditions and diseases that you will experience in the medical world. Now, S/S means signs and symptoms. All right, when we do a SOAP note and we do a progress note, that's super important. So you're not wondering what the heck is that, or what is the nurse or doctor writing there. Okay, so an exacerbation is an acute return of signs and symptoms. This happens a lot with many diseases, infections, as well as chronic conditions. Mortality is the measure of deaths attributed to a specific disease. Okay, so what is the mortality rate from COVID versus the flu? All right, we can compare the two now. We have data over the last 2.5 years. Okay, morbidity is not mortality. You're not dying, but morbidity is a measure. It is measurable. It is observable. It is measurable. And we perform statistical analysis and results based on the level of disability that that disease is causing and the problems related to the illness that it is causing to the individual and to the population as a group. Okay, so for example, if you're going on into your studies at a higher level in nursing or beyond medical school, let's say you're going into residency, you're going to partake and participate in morbidity, mortality meetings. And that's where medical specialists and generalists gather together to discuss morbidity, mortality on a particular topic. It could be a particular disease or an infection, etc. All right, moving on. Oops, I skipped one thing. We did that. All right, I have a very highly sensitive mouse. Okay, now epidemiology. We heard about this epidemiology over and over again during our pandemic. So epidemiologists are a specialty that is going to study population patterns, causes, spread, and effects of what the disease does to groups or populations, right? Disease conditions, as determined via the CDC, okay? Center for Disease Control. If you don't know what that stands by now, you've been living under a rock because we've had the pandemic, right? So we are entering from the pandemic phase, the endemic phase. So now the lay people do not know this term. They're hearing it for the first time, but you're in the medical world now, and you need to know these terms because we're going to use them frequently, and we're going to explain it to our patients, right? So endemic means a disease is continually present within a population, and you get flare-ups and hot zones in specific regions now and then. But at this point, we have reached the endemic phase of the infections that were caused by COVID-19 with all of its frequent mutations that followed thereafter, okay? And you all understand the term very well now because it was across the board, plastered across social media and television and radio. Epidemic means it's a disease that occurs suddenly over a specific geographic location or region. And of course, it spread from one region, from China, across the entire world. And that's when we called it a pandemic, okay? Now, a pandemic is a disease that spreads from country to country worldwide. Obviously, it was quite easy since we travel, so we can get infections if it's airborne on the train, on the plane, in the car, at the mall, at work, everywhere. And that's how we ended up with the pandemic, okay? So in the end, we tried to prevent infections, all right, with previous, historically, we can prevent infections such as polio, all right? But a year ago, there was some rumblings about the wild variant of polio, a mutation that has arisen in the Middle East. And that was like anywhere between 2017, 2018. It was like almost 5 years ago, actually, 4 to 5 years ago. And I was reading in different journal articles, microbiology articles, National Library of Medicine, because I was doing discussion boards on vaccinations. And I was like, oh man, I know it's coming. I know it's coming. And now it's here. So now we have some regions where the actual infection is spreading, despite our perfectly organized methodology of vaccinating the population, all right, and children. And we have the anti-vaxxers that added to that. But one of the components that I found out regarding polio was that unfortunately what happened in Syria, a lot of the children during the war That was around 2013, 2014. They were obviously in a war-torn area and did not get vaccinated. Then they were refugees, and again, vaccination was not there for them. And so somehow this viral wild variant of polio came out. That's one theory. And then the other theory is the anti-vaxxers, and probably both are right, that together it was a recipe for disaster. Okay, so that's everything you need to know with these terms. Now we're going to go on to immunity. So immunity is achieved through either direct infection, or it is achieved through passive immunity and active immunity, which we're going to go over in a minute. So the immune response is going to produce antibodies against any pathogen, any foreign microbe. You can have it inherited through your maternal stay in utero. And it can be acquired or induced through vaccination. So there are two broad types, the active versus passive immunity. And as I said earlier during this lesson, active means that it's produced artificially through the active process of injecting and causing the vaccination to take place, okay? And not necessarily injection, because now we have, for flu, you can take it via nasal, right? All right. And then, so that's artificially induced active. And then there's naturally induced active, which is actually getting sick and contracting the disease. And obviously that's going to be more long lasting. So that's where we're at with active. Now, what about passive? Oh, let me circle back to long lasting. We have discovered that with COVID-19, whether you get vaccinated or whether you had the active infection, immunity doesn't last. Remember, and we had mutations, right? New viral variants coming in all the time. So this is why we had to have boosters. Just so you understand, not that the vaccine doesn't work, we just need boosters to boost our immune system. That's all we're doing. All right. So you have to educate patients on that it's not that the vaccine didn't work. We're just trying to boost your immune system because our immunity wanes after a certain number of months. In this case, we found out with COVID, it's 6 months. And so whether you've got the vaccine or whether you got sick, it doesn't matter. All right. Get that booster. All right. Not to mention the different variants that come out because they mutate. Why do they mutate? Because it's in a very large population, okay, of individuals, since we were in a pandemic. Now, passive means that we are just providing the antibodies against that virus or against that bacteria. All right, when Ebola came out, that was around 2014. It came out in Africa, spread like wildfire there, but it was localized, but a couple of people got out. And one physician got out and came to the United States and landed in Georgia. He did not die. Most people die from this disease. They bleed out of their orifices, eyes, nose, mouth, internal bleeding, and then they lose all their fluids through vomiting and diarrhea. So the cause of death is severe dehydration. It's a horrible way to go. Anyway, this guy, male physician, got it. All right, he was in Africa. They gave him the exact particular immunoglobulin, the antibody from a patient who had the disease. Anyway, he got it early and he lived. Okay, problem with passive immunity, receiving the antibodies, it is short-lived. It is not long-lasting. Okay, whereas active immunity with vaccination or actively getting sick is long-lasting. However, as I mentioned before, how long-lasting? It depends on the virus. So with COVID, it was about 6 months. Now, resistance occurs. Of course it occurs, right? you know, bacteria and viruses, they're kind of like, well, they survive and thrive based on living inside of us, right? So it would behoove them to assure their survival of the fittest. And the fittest that survive are mutants that were not destroyed by the antibiotic. Those mutants arise, proliferate, and then that is the main strain. And so, of course, that's how we get antibiotic resistance. Now, alteration in protein binding is what happens, or the bacteria may be pumping out the antibiotic. The bacteria may actually get like a slime coat around its cell wall structure to prevent penetration of the antibiotic. All right. So how does resistance start? Number one reason is using antibiotics when antibiotics are not needed. All right. So don't beg and don't bug the physician. And if your physician is just knee-jerking it and going, yeah, here's the antibiotic, without doing a throat culture, without doing a blood test, you know that that's overuse of antibiotics, okay? So there you go. But few people do that now. Most physicians know better. You know, times have changed and we have seen the age of overuse of antibiotics is over, all right? Now, here's the difference between bactericidal versus bacteriostatic. Bacteriostatic inhibits replication. Bactericidal is going to kill the bacteria. Which one would you prefer? Obviously, bactericidal. But there are very effective bacteriostatic antibiotics, and maybe perhaps it needs to be used, perhaps due to allergy or whatever intolerance to another antibiotic. Now, you need to learn the term broad spectrum antibiotics. Super, super important. Why? When you don't know the exact etiology cause of the infection right away, because you don't, but you need to put a patient on an antibiotic right away, okay? You put them on a broad spectrum antibiotic that kills a lot of things, but before you do that culture. So if it's a wound that looks really, really, really crappy, it's deep, it's got purulence, it's got an odor, it's got ascending cellulitis beyond the wound, it's got necrotic tissue, that person could go septic. You can't wait. So you do a CBC with differential, find out what's the white blood cell count differential, and see if is it the monocytes, is it the lymphocytes, is it the neutrophils. All right, you can tell what type of infection it is based on the CBC with dip. And of course, a proper wound culture. We discussed that last week on how to do the wound culture and not swab the skin around the wound culture. You got to go deep into the wound and get the appropriate bacteria that's going to be the culprit, the etiology of the infection. So, but before you do all that, you must think about what broad spectrum antibiotic you want to give out. So that's what a physician does. All right. So that's what a broad spectrum antibiotic does. It provides temporary coverage and control of the infection while you wait for that culture result. Once you get the culture result, then you can switch up or add or remove back antibiotic and kill the appropriate antibiotic with the kill the appropriate bacteria with the appropriate antibiotic, right? Okay, so another thing that I want to talk about is what in the world is the mechanism of action? This goes beyond microbiology and goes in the realms of bioengineering, biochemistry, understanding the chemical processes involved in the penetration of this antimicrobial agent, whether it's antiviral or it's antibacterial. It must penetrate the cell wall. It must have an action on the genetics of the pathogen, whether it's a DNA or an RNA. For example, there's DNA viruses, RNA viruses, And does the antiviral agent either diminish the replication of the virus, or does it altogether kill the virus? Or with respect to the bacteria, as I mentioned, does it just, stop the reproduction of the bacteria, bacteriostatic, or does it actually kill the bacteria? That's a bactericidal antibiotic. Okay, so make sure you understand bacteriostatic versus bactericidal. Broad spectrum is what you want to use initially versus narrow spectrum after you've identified the organism through a culture and sensitivity. And then understand the mechanism of action. What is the mechanism of action for that antimicrobial agent? So again, this lesson for you is not at all complete. You need to read the textbook. So for deep, in-depth information, deep diving into all the different mechanisms of actions, you need to read the book, okay? So let's start with some highlights, shall we? We're going to start with the antibacterial agents, the antibiotics as we call them. We're going to start with the beta-lactams. So these are chemically related drugs. All right. They are a group of drugs called the beta-lactams. And what they do is they inhibit the production of the materials that are needed to make the bacterial cell wall. If we're not making the bacterial cell wall, guess what? Bacteria die. They need a bacterial cell wall to live. Okay. So we discovered it through mold on bread, right? Because antifungals are great. Here's the thing. Antifungals are great to kill fungus, but fungus among us is not a bad thing because we found out that fungus likes to protect itself as well against guess who? The common enemy, bacteria. Okay. So anyway, long story short, we have the penicillins. From there, we developed cephalosporins, we have monobactams, carbesiphims, and carbapenems. Okay, so these are different varieties of these beta-lactams, okay? It kills the beta-lactam ring on the cell wall, and bam, we're done. We've got those critters killed. Quinolones. These are a group of antibiotics that will block two enzymes responsible for DNA growth. So it inhibits the growth of the DNA, which is therefore good because it leads to the breakage of DNA and subsequently bactericidal activity, meaning it kills the bacteria. Prolonged use will cause mutants to arise and superinfection. And quinolones are bad, and here's why. Anyone with, for example, a collagen disorder like EDS, anyone who has surgery for a tendon, anyone who has tendonitis, anyone who's diabetic, these are issues because quinolones cause tendon inflammation. And by doing that, it leads to rupture. Even after the medication is discontinued. I can't tell you how many physicians didn't know about this and were prescribing ciprofloxacin. Everybody knows Cipro to diabetics, to people that are vulnerable. For example, let's say postoperatively, someone gets a urinary tract infection, but they had a total knee replacement or a total hip replacement, or they had shoulder surgery, right? Arthroscopy. Whatever the case may be, now they've got inflammation. They are completely vulnerable because there was a ton of work done in the hip and the knee, right? Tendons were cut and reattached and sewed and now they got a post-op infection, urinary tract infection, and they were put on ciprofloxacin. A huge no-no, okay? I give you these examples, not because I want to scare people, but I give you these examples because then it sticks in your brain. Oh yeah, that's right. She said quinolones are contraindicated in people who have inflammation, tendon inflammation. So we know who those are. We know who those people are. All right. So just don't do it. Don't, if you become a physician, don't provide quinolones to someone who has chronic inflammation. Even for someone like, example, someone who is in the midst of the Epstein-Barr virus, right? They're trying to heal from it and they're at home and they are in an inflamed state, right? Someone with IBD, inflammatory bowel disease, big no-no, all right? So I beat that to death. I'll keep going. All right. Aminoglycosides. So the aminoglycosides are very strong antibiotics. These are going to cover gram negatives, and they are bactericidal. Very, very risky. You want to do this when they're in the hospital, IV, and you also want to do check peaks and trough levels in the blood and make sure you either decrease the dosage or increase the frequency time in between so that you don't damage the liver, and inadvertently you may cause hearing loss from these antibiotics. All right, why would you use aminoglycosides? Well, gram-negative infections are super, super bad. And so you want to go with the big guns: amikacin, gentamicin, tobramycin. Just check peaks and troughs, you'll be fine. Nurses, you'll be checking those and reporting on those, and make sure that the patient's creatinine levels, BUN, are within normal limits while taking this antibiotic. Okay, glycopeptides. These are bactericidal. All right, so this is a wonderful antibiotic. Unfortunately, same thing, you got to do peaks and troughs. It may cause kidney damage. Number one. Number two, because it was used so frequently, vancomycin, we now have vancomycin-resistant Staph aureus. So it is bactericidal. It is great for gram-positive infections. So we would use vancomycin for severe ascending cellulitis, with a wound that is severely infected, necrotic tissue. Typically, diabetics are susceptible to these kind of infections. And so vancomycin was the go-to, and you need to monitor the serum blood levels, like I said, peak and trough. Unfortunately, like I said, we've developed resistance, and now we use cubicin, telavancin, and it's used QD instead of more frequently like vancomycin. So QD means once a day, okay? All right, next group is the macrolides. These inhibit bacterial protein synthesis. So the macrolides are they're unfortunately not bactericidal, they are bacteriostatic. They are commonly used for pulmonary infections. The use is mainly for pulmonary infections and for patients who are allergic to other antibiotics. They're called macrolides for a reason. They're not commonly used unless a patient has, for example, an allergy to, I don't know, penicillin or something like that. So let me give you an example: erythromycin. All right, now let's go on to tetracyclines, not used much anymore. If you use it on a child, it is very, very severe. And if you're a physician, this is not a good thing. Nobody uses this. If a child receives tetracyclines, they get permanent tooth discoloration, their teeth turn black. So not used anymore. It is a broad spectrum antibiotic. It is bacteriostatic, and it is not bactericidal. Okay, another one, folate inhibitors. These are bacteriostatic. They're used for UTIs. These are called sulfonamides. And another group that we have is the quinapristine-dalfopristine. So these are, again, bacteriostatic. They inhibit protein synthesis of the bacteria, so they eventually die. Again, bacteriostatic against gram-positives, and IV is the usage of these antibiotics, IV only. All right, this is the one, daptomycin. This is the one that's really good. It's useful against MRSA, MRSA, methicillin-resistant Staph aureus. It is bactericidal. It is great against gram-positive bacteria. And unlike the other antibiotics, it will interfere with the electrical activity of the cell membrane. If you remember, depolarization and the sodium, potassium pumps, and that is going to open and close certain parts of the membrane with the different receptors. So it inhibits. It's a whole slew of biochemical interventions that I'm not going to go into here. But if you're interested, by all means, go out there and research it. It's pretty cool. All right, clindamycin. Clindamycin is anaerobic, great against anaerobic bacteria. It is also great against gram-positive cocci. And what's great about clindamycin, it can be used both orally or IV. Okay, so with severe infection, you want to do IV. All right, so mixed groupings of various bacteria. A lot of diabetics will get mixed infections. So clindamycin is great because it covers it all. It'll cover the anaerobic bacteria, the gram-negative anaerobes, and the gram-positive cocci such as staph and strep. Now, metronidazole is a common synthetic drug that's used for anaerobic infections, flagell. It inhibits protein synthesis, resulting in cell death. Usually it's not given alone. It could be part of a cocktail drug. Example for PUD, peptic ulcer disease caused by Helicobacter pylori, we definitely use metronidazole, but like I said, it's in a cocktail. Now, let's talk about the specific anti-tuberculosis drugs. So TB, we understand that, you know, it's airborne and it can enter the lungs. It could be the active bacteria or the spore form, which then when it's an active, when the spore becomes active, the bacteria is released. Okay, well, it doesn't just go to the lungs. It goes to the kidneys, it goes to the spine, it goes to the brain. It could even create cysts in bone. All right, the most important thing that you need to remember is you know, using proper precautions. If you know someone is TB positive in the active stage, they need to be isolated. It's an airborne transmission. Someone can have chronic TB. And like I said, the spores could be latent, dormant there for years. Okay, so MDR TB, this is due to suboptimal treatment. So what is that? That means that the patient was non-compliant. You're supposed to take the antibiotics for a year. This is really hard for patients. Non-compliance is high with respect to treatment of tuberculosis. The drug of choices are rifampin and isoniazid. All right, now let's move on to, again, please read the book. This was all just highlights. I by no means have covered it all. Those are all the antibiotics that are the most popular. Okay, you could study for 2 months just antibiotics. Okay, I'm moving now to antivirals. Since we're doing medical microbiology, we really have to cover a little bit of everything. Okay, and not a lot about one thing. So really, we are dilettantes in this course. But if something piques your interest, please, by all means, dive deep and go into these antimicrobial agents and study them, because it is amazing. And you will learn the field of bioengineering and understanding the engineering involved and the manipulation involved to kill these pathogens. All right, let's move on. So antivirals, the first one I'm going to go over is HSV. The treatment interferes with viral DNA synthesis. So what's HSV stand for? Herpes simplex virus, whether it's herpes simplex 1, which is seen as a lip sore, or herpes simplex 2, which is seen on the genitals as a sore. The active stage is the contagious stage, so definitely If someone has it, stay away. And not only that, someone with herpes, the virus is forever. They are forever married to this virus. It is latent in their body. And then magically, I mean, it's not magic. It is really an opportunist. The virus is an opportunist when your immune system is down, when you're tired, when you're fatigued, when you're not eating right, when you are not getting enough sleep, when you're stressed out. If you have HSV, bam, it hits you like a bullet, like you will know, okay? And then the sore appears. So what do? Acyclovir, all right, valacyclovir. These are the treatments, all right? Now we move on to another topic, influenza. Everyone knows this. Obviously, just like with COVID, prevention is the way to go. So we always recommend vaccination. Nowadays, you don't just need, you can get away without the injection. You could administer it orally. You could administer it via inhalation. So there are many ways that you can get this influenza vaccine. All right, moving on, RSV. So RSV is a disease that happens more in children. It is the culprit of lung disease in children. And the treatment for that is ribavirin, which inhibits the RNA and the DNA viruses. All right, so you're probably only going to see this in children under 3 years of age. Next one, HCV. This is the most common bloodborne infection in the United States. Okay, so hepatitis C, you could do cimaprevir and peg interferon. These are some of the treatments for that. And the big one that everyone knows and everyone fears, needle stick, you're more likely to get hepatitis than HIV. But let's discuss HIV. HIV is diabolical. What happens is the virus comes in and inserts itself by a reverse transcriptase enzyme, which is going to create a DNA that can insert itself into the DNA of the human cell. And then every time the cell divides and undergoes protein synthesis per se, then the HIV virus is also there forever. It becomes part of the DNA of the individual. All right, that's how HIV mechanism of action occurs. It infects the cells of the immune system. What cells? The T helper cells. If the person does not get treated, that it will eventually progress to AIDS. AIDS stands for acquired immunodeficiency syndrome. Remember what I mentioned, syndrome is a series and groupings of signs and symptoms. When someone is in full-blown AIDS, they have other opportunistic infections such as oral thrush, which is a yeast infection, Candida albicans of the mouth. They can get Kaposi's sarcoma, which are small skin tumors that can eventually kill them. They can get all kinds of infections, lung infections that are mixed, not just bacterial, viral, but it can definitely be fungal. All right, so what's the drug of choices? Notice I said choices because it's always going to be a cocktail. They are the antiretrovirals. We know that the enzyme that converts the virus into a DNA sequencing that can be sequenced into the DNA of the human cell, that's how the mechanism of action occurs. All right, so the HIV is inserted into the DNA of the human. So how can we stop that? Antiretrovirals. That's how we stop that. So in the 1990s, we came up with cocktails, and by now we have a really good hold on how to manage HIV. An individual could live an entirely normal life as long as they keep taking their cocktail drugs. They can keep their T cell count normal and almost invisible. Although they know they're HIV positive, obviously they have to make sure they don't infect anyone else, and they can live a nice long life. All right, whereas When it first came out, people were dying left and right. 1990s, people died by their 40s or 50s, especially the ones that didn't have access to medical care. All right, so abacavir, efavirenz, and ritonavir. So these are the drugs. Now, we move on to the antifungal agents. The antifungal agents are either going to hit the yeast or the mold. The mold is fungus, fungus among us. Fungus can be local, such as on the nails, or it could be systemic. If it gets into the blood, we are in serious, serious trouble. So the treatment is obviously an antifungal. Everyone knows the over-the-counter topical antifungal treatment, nystatin, miconazole. There's all the different types. There's oral antifungal agents such as diflucan orally, Lamisil, Sporonox. These are all the antifungals. Why do I know all these? Because I was a podiatrist. Always saw fungus among us. Okay, so to summarize, we have done a lot with this lesson. I went way beyond what the PowerPoint is displaying here, and gave you thoughts and contemplation on many things. But to circle back and summarize, you need to remember, for the purpose of assessment, understand the difference between passive and active immunity. Understand the microbial, the antibiotic resistance that rises with overuse of antibiotics, okay? Microbial resistance mechanisms. Understand the different antibacterial agents, the antitubercular agents, the antiviral agents, and the antifungal agents. All right, that is it. I do hope that you enjoyed this lesson, and I'm going to stop sharing now. And feel free to contact me if you have any questions. Bye-bye.